share my screen, so just let me know if you start to see it.
Yep, it's clear.
Okay. So for those of you who don't know me, my name is Ayat Ghafouri, as the Dr. kindly introduced me. So I am a clinical pharmacist working at Nottingham University Hospitals. I did do a talk around a week and a half ago discussing the UK's government response to COVID-19. And because of my background being a pharmacist and being essentially more involved within the medicine side of coronavirus and the treatments, I thought it would be nice to also discuss the treatment options available in the UK currently as well. So this is what we will be doing today, and I hope that everyone kind of benefits from it and we all learn from each other, because that is essentially the main aim from it. For those of you that have questions as well, I'd be happy to answer some questions at the end of the talk as well, so please keep that in mind. So just to give you a quick snapshot in terms of the current status within the hospital that I work in is based over 2 separate hospitals, so it is quite a large hospital trust, and since the beginning of the coronavirus, we have discharged currently 432 patients. So in the grand scheme of things, it doesn't sound that much, but for the amount of patients that we're seeing come in, it's, alhamdulillah, it's quite a good number. Those patients are being treated and they're being discharged back home. We currently have 158 inpatients. So these are patients that are currently being treated within the hospital. When I say treated, they could either be on intensive care units or they could just be on a standard ward where they are receiving supportive care. And unfortunately, we have had 200 patients that have passed away from the coronavirus. So that's around 22% of the patients we've seen. So it is quite a large percentage, which is why I have quite a big passion in terms of understanding why the coronavirus has manifested in this way, because we are seeing that it's affecting a lot of patients, and unfortunately it is causing a lot of deaths as well. So before I go on to discuss the theory behind, before I go on to discuss the treatment options, I thought it would be useful to actually discuss the theory behind these treatment options and to briefly touch upon how the virus essentially works. So for those of you that aren't aware with how the virus works, so it's a virus that we know has what we call S proteins on it, so all spike proteins. They could be called either thing, so spike proteins or S proteins. And from the page you can kind of see it's the purple spike that we're seeing on the coronavirus. These S proteins have an affinity for ACE2 receptors. Now ACE2 receptors are found on a variety of found in a variety of places within the human body. Essentially what's happening is this receptor is bound to the virus, and we're getting a bond between the human cell and between the virus. Now it is important to note that the virus itself will not enter the human cell without something called a serum protease enzyme. Serum protease enzymes are found on the lining of the human cell. And these are quite important in a sense that they will give permission to the virus to enter the cell. So I kind of put the analogy of them being like bodyguards, because they can't enter the human cell without permission from the serum protease enzyme. So essentially what we're happening is the virus is binding to the ACE2 receptor and it is entering the cell, and it's injecting its viral RNA into the host cell. And this is where we are seeing replication and duplication of the virus and essentially the spreading of the virus within the human cell. Now, for us to understand exactly how it works, there are a number of places where the ACE2 receptors are found. So ACE2, for those of you that don't know, they are found within the lungs, which is essentially why we are seeing a variety of respiratory symptoms with the virus. It's also contained within the heart and the blood vessels, specifically within the endothelial cells of the blood vessels. It's also contained within the GI tract, so the GI system, the gastrointestinal system. So this is why we are getting symptoms such as nausea or abdominal pain. And most remarkably, it is contained within the kidneys. I would be happy to discuss the effect of kidneys in more depth after the presentation if anyone is interested, but the kidneys has quite a bit of a management issue when it comes to patients with coronavirus, because we are seeing the development of acute kidney injuries in these patients. So essentially what's happening as a result of the virus binding to these cells are two things. The first of which is the direct cytotoxic effect, which basically means that the cell is dying, and that's as a result of the virus entering the cell. The other is the hyperinflammatory phase, also known as a cytokine storm. So this hyperinflammatory phase occurs because our immune systems are reacting to the viral load of the virus, essentially. So we're getting an increased number of IL-1 inflammatory cytokines being released, IL-6 and also TNF-alpha. And these are cytokines that are creating that inflammatory response. And yes, they are, they are fighting the virus for us, but in the same way, they are also causing harm to our bodies. So this is where a lot of the treatments come in as well. So I will discuss that in more detail in the next slides. So for those that did attend my last presentation, I did talk about the recovery trial. So very briefly, I will go over it again, and then we will discuss the newer medications that have come out in the last few weeks. So for those that don't know, the recovery trial is a randomized evaluation of COVID-19 therapy, and it's been piloted by the University of Oxford. And it is essentially 5 arms of treatment that is randomized. Now, patients are eligible for randomization if they are over 18 years old, they are admitted to hospital, and they have proven or suspected coronavirus. And these arms are essentially very well known around the world currently. So I think a lot of people have heard about these different treatment methods. So the first of which is, the first arm is just no additional treatment. So if you're randomized and you get no additional treatment, you will purely be treated with oxygen and antibiotics and fluids. In that sense, it will be more of a supportive treatment method. And then lopinavir and ritonavir is an anti-HIV medication. Dexamethasone is a steroid, and hydroxychloroquine is a antimalarial medication, typically known as an antimalarial medication. And azithromycin is typically known as a macrolide antibiotic, used very, very often in patients with COPD and any kind of inflammatory disorder as well. So in terms of the outcomes from this trial, the main primary outcome is death in the bluntest way possible. We want to basically avoid patients passing away. The secondary outcome is the duration of hospitalization, whether or not that patient then goes on to develop a need for ventilation, and whether or not that patient goes on to develop a need for renal replacement therapy as well. And generally what we're doing is we're giving these treatments for 10 days. Patients are then getting better, they are being discharged, and then we are following them up 28 days after discharge to check that they are all okay, and to establish whether or not the treatments have worked. So in a bit more depth, so lopinavir and ritonavir, it's an antiviral in a sense, and it is a HIV protease inhibitor, which is combined with ritonavir to increase lopinavir's plasma half-life. And it has been shown to have some activity against the SARS coronavirus and also the Middle Eastern respiratory syndrome coronavirus as well, that was around a few years ago. So that's the lopinavir and ritonavir. We're not too sure exactly how lopinavir works. Unfortunately, there's still so much research going on, but what we do know is that it has shown some activity against SARS, and the coronavirus. Now, low-dose corticosteroids is something that's quite common, I would say, in a lot of inflammatory disorders. So corticosteroids generally is the favorable immune response modulation for quite a lot of inflammatory disorders, like I said. So we can either give this orally or IV, depending on how unwell the patient is. Hydroxychloroquine as well has been used for many, many decades to treat malaria and rheumatological diseases. Now, hydroxychloroquine is the one that has a lot of media attention. Again, we don't 100% know how hydroxychloroquine works. What we do know is that there is some sort of the endocytic pathway, which is essentially preventing the coronavirus from entering the cell. So there is some sort of mechanism there that we don't quite understand fully, but we do know that it has some sort of activity against the entering of the cell in terms of the coronavirus specifically entering the cell. So that's essentially why we're using hydroxychloroquine. And it is quite an unusual dosing regimen. So for those of you that are familiar with hydroxychloroquine, we tend to use it once a day in those patients that are have malaria. However, in patients with COVID, we are giving them a loading dose. So essentially we're giving them 800 milligrams straight away. Following that, we are then giving them 800 milligrams again after 6 hours. And then after 12 hours, we are then giving them 400 milligrams, and then they continue 400 milligrams twice a day for 10 days just to see the effects of the hydroxychloroquine. So it's a bit different in a sense that it's a completely different loading regimen that I have seen in this case. One thing to note with hydroxychloroquine that I previously said as well in the last presentation is that it's known to be quite a difficult drug in terms of monitoring, and also in terms of the cardiac side effects that we get with it as well. So with hydroxychloroquine, we do have to provide continuous ECG monitoring, and we also have to be wary of the fact that it interacts with a wide variety of medications, and we also do see that sometimes it will prolong the interval. So that's something that, as a pharmacist, I tend to have a big involvement in terms of reviewing the medication and just making sure that the medication the patient is currently on, for example, antibiotics, do not interact with hydroxychloroquine and will not cause further harm to the patient. The other domain within the recovery trial is azithromycin. So, like I said previously, azithromycin is a macrolide antibiotic, very similar to clarithromycin, which we also do use in those patients. But azithromycin has also been shown to have immunomodulatory properties in inflammatory lung disease. So this is the justification for using azithromycin within coronavirus patients. Now, the new trial that I wanted to discuss is a trial known as REMAP-CAP. Now, this is a randomized, embedded, multifactorial, adaptive platform trial for community-acquired pneumonia. It's quite a long-winded title. But essentially, this trial was around way before coronavirus happened, and it was focusing on the treatments for community-acquired pneumonia. It's a trial that I believe started in Saudi Arabia, so I think it's a professor in Saudi Arabia that has piloted it, and it is being used around the world today. However, what they have done is created 2 new domains for coronavirus, essentially. So we are employing people onto the clinical trial with the intention that this is for treating coronavirus as well as pneumonia, because as I discussed in my last presentation, coronaviruses tends to go on to produce pneumonia and also go on to produce acute respiratory distress syndrome. So all of this kind of ties in together, which is why it has been chosen as a trial to be piloted within the UK in those patients with coronavirus. Now, in terms of the COVID-19 domains, so the existing that they did have, similar to that of the recovery trial, they have the macrolide therapy, so that's azithromycin. They also had corticosteroid therapy. So this is essentially the dexamethasone or prednisolone. So I won't talk about them too again. The antiviral domains, again, are very similar, so lopinavir, ritonavir, and hydroxychloroquine. The only thing that's different with this one is that it also provides a new domain for combining both lopinavir and hydroxychloroquine together. The reasoning behind this is somewhat unknown. However, they believe that it's because both of these antivirals work in a different way, basically giving them together will provide some sort of synergistic treatment for those patients. So we basically provided that as a separate domain. However, I'm not too familiar with the combination because we don't tend to do that within the hospital, purely because there is quite a lot of complications in terms of the combination of two medications together. Now, what's new and what I will be focusing on with this presentation as well is the immune modulation domain. So this is including interferon beta 1A, anakinra, which is an interleukin-1 antagonist, and tocilizumab. Now, I'll be discussing these in more depth on this slide. So just to start with, if we go back to the slide where I was talking about how the virus actually works, I discussed the fact that we have this inflammatory phase, and then we have this development of interleukin-1, interleukin-6, and TNF-alpha. Now, these are cytokines, and they're inflammatory markers that are essentially fighting the virus, but at the same time can cause harm to our bodies as well. So this is known as the inflammatory phase, or the cytokine storm, as some people may have also called it as well. So these medications on this slide are targeting those cytokines and those inflammatory markers. So it's not essentially stopping the virus from entering the cells. These treatments are stopping the virus once it has already taken its action. The virus has already entered the cell. It's already caused cells to break down. So these treatments are only really offered to those patients that are very, very critically unwell, and generally they are in intensive care units, and they are essentially being ventilated. So these treatments are, in that sense, this is how we are using them. So with interferon beta 1A, this is a COVID-19 basically, sorry, COVID-19 blocks the interferon response during critical illness. So interferon beta 1A is one of the receptors that one of the cytokines is being released. So essentially this medication blocks the interferon response, and we are enhancing the endothelial barrier function through upregulation of the production of adenosine. For those that aren't familiar with adenosine, it is part of it makes part of the DNA. So the upregulation of the production of adenosine just essentially means that we are strengthening the DNA within a cell, and it's less likely to break down in this sense, and less likely to break the barrier and release the virus into other cells and pass it on to the surrounding interstitial fluid. So this is how interferon beta 1A essentially works. Again, with all of these with all of these treatments, unfortunately, we don't know too much about them. This is all theoretical, but there is promising data out there to suggest that they may potentially be treatment options for the long term and for future use in coronavirus as well. Now, with anakinra is it is an interleukin-1 antagonist. So if you think back to when I said one of the cytokines releases interleukin-1, essentially what's happening is in these patients with coronavirus, those that are critically unwell are going on to develop acute respiratory distress syndrome. I spoke about acute respiratory distress syndrome in the first presentation quite a lot, but essentially it's where the lungs are not able to breathe for themselves. So those patients have to be ventilated. Now, in these patients, in patients with acute respiratory distress syndrome, there is evidence that cytophagocytosis occurs. So cytophagocytosis is essentially cell death. When a cell dies, it then presents with another syndrome known as macrophage activation syndrome. And then this goes on to produce what we know as interleukin-1 mediated disease. Now, this interleukin-1 mediated disease is an inflammatory response from our bodies, and it is essentially there as more of like an inflammatory phase, so the hyperinflammatory phase. And what we want right now is so in patients in intensive care, we want to essentially suppress their immune system. Now, this isn't purely because we want to prevent that immune system from fighting the virus, but we believe that the patient has got to a stage where their immune system is not able to fight the virus on their own. There is no chance that if you are in intensive care, that your body can fight that virus on your own. The patient's body is very weak. It has reached a state where it's trying its hardest, hence why it goes into hyperinflammatory response phase. But unfortunately, that hyperinflammatory response is never really enough to for the patient to recover. So this is where we come in as the doctors and the pharmacists and the people looking after those patients. We are essentially trying to stop that inflammatory response from happening and take over treatment and take over breathing for that patient. So in those patients that are in ICU or in the intensive care units, we are ventilating them, so we are treating them ourselves and breathing for them. We are also giving their body a bit of a break, if you want to say it in that way, so that the body then recovers by itself and we kind of do the breathing for them and do the living for that patient. So this is why we want to essentially stop that inflammatory phase, which is where anakinra comes in, because it's preventing that interleukin-1 mediated disease that we see. The other one, quite interestingly as well, is similar to anakinra, so it's tocilizumab, and so it's a monoclonal antibody, a humanized monoclonal antibody that inhibits membrane-bound and soluble interleukin-6 receptors. Now, in patients with COVID-19, like I said, we see an increased secretion of IL-6 cytokines being released from monocytes. So tocilizumab works with the IL-6 receptors, whereas anakinra works with the IL-1 receptors, and interferon beta-1a works with the TNF-alpha receptors. So all of these immune modulation categories and treatments, work on the different cytokines. So we would never give them all together, purely because that is too much immunosuppression for one person. But it is having one or the other has shown to be of some benefit in those patients that have entered the hyperinflammatory response and are unfortunately too well to fight the virus for themselves. Now, I do get a lot of questions in terms of why would we want to interrupt the inflammatory response if it's actually helping the patient, or if it's our bodies fighting it. But like I say, to go back to the main point, acute respiratory distress syndrome is the primary driver for mortality. So in those patients that are developing acute respiratory distress syndrome, unfortunately, the percentage of mortality, or the chance of them not recovering, is quite high. So what we want to do is interrupt that inflammatory response, interrupt the cytokine storm, control the acute respiratory distress syndrome. By that we mean ventilate, and as a result we are then decreasing mortality. So those patients are being allowed to have a chance to actually live and recover from the coronavirus as well. So this is why it kind of sounds counterintuitive to block an inflammatory response in the middle of a virus, but there is reasoning behind it, and it tends to work. Now, briefly, the last presentation did prompt a few questions, and a few people asked me, what do we do with coronavirus in children and in young people? And now, just for a bit of background for myself, I don't work in pediatrics. I've very, very rarely come across children and deal with children. If I do deal with children, it's usually when I'm on call. So an on-call shift just states that I'm working overnight and I get called for critical patients. So I sometimes have some experience with pediatrics in that sense, but generally I am not dealing with children at all. However, I do know that we have had some children come in with coronavirus, unfortunately. I do want to note, though, that the children that have been coming in with coronavirus have been children that have previously been unwell anyway. So unfortunately, these children already have other comorbidities, and it tends to be either cancer, or it tends to be a rheumatological condition, or a neurological condition. So these patients already have comorbidities, so they're more susceptible to developing coronavirus. But what we are finding is that children are recovering much easier than adults in this sense. We're not entirely sure why, but we do believe it's possibly because their immune systems are just a bit more receptive to newer viruses, and the nature of children is that they tend to get viruses and get illnesses, and they will recover from them quite quickly. However, just to touch on it quite briefly, we do have a guideline for coronavirus in children, and this is essentially the main things that have come out of it. I do want to note that none of the clinical trials are being offered in children, purely because the physiological makeup of a child is very, very different to a physiological makeup of an adult. So we cannot offer these treatments to children, purely because we do not know how they work, and it would be, there's just too much risk for giving it to a child. So far, we haven't been in a situation where we have seen a child critical enough to need any of these treatments anyway. So in this case, it's kind of worked out. So in terms of treating the children, we do offer them oxygen, and we try to aim for their saturates to be over 92%. Now, generally in an adult, we would aim for 94 to 98%. The reason we aim lower in child is just purely because their lungs are a little less immature, and they just need a lower saturate concentration, and they tend to do quite well on above 92% of oxygen. In terms of antibiotics, we tend to go with coamoxiclav or cefaclor, or in patients with penicillin allergy, we will then go to levofloxacin or clindamycin. These can be given IV in those patients that are maybe a little bit more unwell, or if they can't tolerate anything orally, we do have IV options as well. Antipyretics, so this would just be regular paracetamol or Tylenol. If you're American, that's what it's called. So these are just given to the younger patients as well, and also to the adults, just to maintain their fever. The one thing that is quite important to note is that steroids, especially systemic steroids, should not be used in children. It is thought to prolong the viral shedding and is an immunosuppressive agent, which we don't want to use in children. Yes, we want to use it in adults, because with adults we tend to see more severe disease. However, in children, it is thought best to allow them to recover from the virus with supportive care only, without allowing us to kind of give them steroids and prolong the viral shedding and just increase the number of hours or the number of days that the virus is living within that child. So far, the good news is that we haven't had a child pass away, thankfully, and we haven't. Most of the children that are coming in are recovering very, very well. So it's not something that we are too concerned about in that sense with children. Now, just to summarize, and then we can go on to take some questions. So we have a very big focus on ACE receptors. Like I said, the virus is binding to these receptors, and unfortunately or fortunately, depending on how you want to see it, these receptors are contained within very key organs within our bodies. So unfortunately, is causing acute kidney injuries. It's going on to develop stroke. It's going on to develop acute respiratory distress syndrome. So there's quite a few virus binding to the ACE2 receptors. And then the two main things that, in terms of treatment, that the UK is focusing on is antivirals and immune modulation. Just to reiterate, all of these treatments are in their very early stage. We don't know for sure if any of these are working. However, from my perspective as a pharmacist, I'm thankfully seeing that a lot of patients are recovering, and they are responding very well to these treatments. We're not too sure if it's the treatments itself that's causing the patients to recover, or if it's purely because they are in a position where they're being treated with oxygen. So we're a bit unsure in terms of what it is that's causing it. However, the treatments are there, so this is currently what we are using. Thank you very much. So I'm happy to take any questions. I've also left my email there because I did have a few questions last time from people that wanted to send it to my email. So for those of you that do want further clarification on anything, feel free to ask via email, and I'm happy to take any questions now as well.
Thank you so much, Ayat. It was like an interesting talk. Now, if any of the audience has a questions, please raise your hands, and please be advised that all the questions should be in English. Is that correct, Ayat?
Yeah, I do speak Arabic as well, so I'm more than happy to answer them in Arabic, although it might be a bit mkessar. but English is fine as well.
Okay. So أي من الحضور يحب يعني عنده سؤال معين بإمكانه أن يوجه السؤال إلى دكتورة آيات. عندنا يمكن أكثر من شخص، أكثر من واحد من الحضور رافع إيده على مود أسئلة. عندنا زينب جاسم. عندنا زينب جاسم ما موجودة. عندنا الدكتور سلوان علي الحمزاوي اللي هو عميد كلية العلوم المحترم، إن شاء الله عنده مجموعة من الأسئلة حاب يقدمها هنا بالبرزنتيشن.
تفضل.
دكتور سلوان.
نعم دكتور بسام، نعم اوكي، شكرا جزيلا. Thanks a lot, Dr. Ayat, for your valuable info, and really I'm so interested and gaining new experience for me. And just I have a couple of questions. First one, just I'm wondering about the effects of the virus on the kidneys and the development of the acute kidney injury. Okay. And okay, let's start with the first one.
So in terms of the virus and the effect on the kidneys, so just a bit of background, we are seeing around 5 to 19% of patients that are coming in are developing acute kidney injury. So for those that don't know what acute kidney injury is, it's kind of in the name. So acute means it happens very quickly, and injury just means that the kidney has received some sort of injury or some sort of damage. So it's not filtering the toxins out of our blood in a sufficient way. So we're seeing a buildup of toxins essentially. So this is essentially what acute kidney injury is. Now, when I go back to the slide on how the virus actually works, we see that we got the ACE2 receptors are actually on the kidneys as well. So within the kidneys, we have the nephrons. So the nephrons are the filtering station, or the filtering hub, as you say, of the blood. So essentially we have blood, all of our blood goes through our kidneys, and we are then filtering out anything that's toxic, so that then produces urine. And then we also, on the plus side, we have the reabsorption of anything that's useful back into our blood. So there is a very, very thin barrier between our blood and our urine. And this barrier is lined by a bunch of cells, the endothelial cells, and these cells have the ACE2 receptors on them. So you can kind of see where I'm going in a sense, where so the virus is binding to those cells on the barrier between the blood or the interstitial fluid and the urine, and it's causing that cell to then be broken down, or basically that cell is dying because the virus has become part of that cell. And what we're seeing is that the barrier between the interstitial fluid and the urine is broken. And that broken barrier is then leading to leaking between the interstitium and the urine. So what we're having is a lot of the patients that come in will have proteinuria, will have albuminuria, and will have hematuria. So albumin is protein, so we use the two phrases interchangeably, proteinuria and albuminuria. Essentially what we're seeing is that we are having a lot of protein in the urine where it shouldn't be there. It should be in our blood, it should be in our plasma. And also we're having hematuria, so hemoglobin is essentially it's quite a big component, but it is being leaked out into the urine. So we're getting blood in the urine as well in a lot of the patients. As soon as we see these two things, we know straight away that, okay, there's been some sort of kidney damage here. And we also recognize that as soon as there is kidney damage, we establish that the virus has had quite a big effect on the patient. Because we do have a lot of people that come in with the virus that won't develop kidney injury, but it kind of just highlights to us that those patients maybe have less of the virus, or they have a lower viral load than those patients that are developing kidney injury. So what's essentially happening is the virus is entering the cells surrounding the nephron. It's causing a cytotoxic effect, so those cells are dying. It's then causing that barrier to break down between the interstitial fluid and the urine. And unfortunately, we're getting a lot of useful proteins and a lot of useful nutrients as well, and electrolytes being filtered out into our urine. So this is essentially what's happening in terms of acute kidney injury. And also, so for those of you that are familiar with the kidney, the creatinine is increasing. So creatinine is used as a marker for how well your kidney is filtering toxins out. So in those patients that are developing acute kidney injury, we will see a creatinine marker of anywhere between 300 to 400, which is very, very high, considering it should be about 40 to 70 or 40 to 80. So this is essentially what's happening in terms of the kidneys with the coronavirus, if that makes sense.
Okay, it makes sense. Yes, thanks for your clarification. And the second one, just and why are seeing an increase in strokes in patients with coronavirus?
The strokes.
Yeah, strokes. Yeah, exactly.
So in a similar way, the receptors are also so the ACE2 receptors are actually also found within the endothelial cells that line blood vessels. So if you think about it, the heart has the aorta, but it also has a number of other blood vessels that send blood all the way to different parts of the body, specifically towards the lungs as well. So what we're having is within these veins and these arteries, they are lined by endothelial cells. Now, for those of you that know, an artery is usually quite narrow anyway, and it is in a state where it can be inflamed or and it can be normal as well. Now, in coronavirus patients, we're seeing that the virus is then attaching to the ACE2 receptors on the endothelial cells within, the endothelial cells lining the arteries, and this then develops cytophagocytosis. So we're getting the cell, we're also getting inflammation of the cell. Inflammation within the cell then leads to narrowing of the artery. And as you can imagine, if you're narrowing an artery, you're more likely to get clots develop. So this is how heart attacks and strokes happen. It's where we essentially get narrowing of the artery. Typically, narrowing of the artery usually happens if we have high cholesterol levels or if we have high blood pressure. But what we are seeing is that there are some patients that have had no history of cardiovascular complications. And unfortunately, because of how much virus they have, so we call this the viral load, because they have such a high viral load, they are then discovering that, okay, we're seeing a development of clots in these patients. And unfortunately, those clots are then causing strokes and they're causing pulmonary embolisms. What we are seeing is that the nature of these clots, they tend to be smaller, so we call them microthrombi. So it's in the name, so micro means tiny and thrombi is the thrombus for the blood clot. Now these microthrombi, they will develop within the veins, but they tend to travel. So they're not small enough to block a vein or to block an artery, but they will travel to the other organs. For example, it will travel to the brain. If it travels to the brain, it will then cause a stroke. If it travels to the lungs, it will cause a pulmonary embolism. If it travels all the way down to the calves, it will cause a deep vein thrombosis, also known as DVT. So there is a bit of an issue there. However, we are seeing that the patients that are coming into hospital, we give them, we put them onto VTE prophylaxis anyway. So this is venous thromboembolism prophylaxis. So it's the prevention of that. So this will be stuff like enoxaparin, tinzaparin, and dalteparin. So these are typically what we would give a patient when they are an inpatient with us to prevent that from developing. But I have unfortunately seen one or two of my patients have gone on to develop pulmonary embolisms after recovering from coronavirus. So it is something that is quite serious as well.
Okay, got it. Thanks a lot, Ayat. Thanks.
Are there any more questions?
Hello.
Hello.
Yes, thank you everybody, and thank you, Dr. Ayat, for your nice presentation. And I want to ask you about the role of anti-malarial drug in children. Can I know the benefit of anti-malarial drug in children?
Yeah, okay, so the anti-malarial drugs that we are using for coronavirus, namely the hydroxychloroquine, we're not using them in children at all. We don't exactly know how the child will respond to hydroxychloroquine or the anti-malarial, and we also haven't been in a situation where any child has been critical enough to need an anti-malarial. 9 times, well, not 9 times out of 10, all of the younger patients have recovered with just oxygen and antibiotics and fluids. So we haven't been in a situation where we have had to use an anti-malarial. So unfortunately, I can't really answer that because we don't really use the anti-malarial in children at all. So in that case, I don't really have an answer for you, unfortunately. I do apologize.
Thank you.
That's okay.
Thank you so much. Thank you, Ayat, and thank you. I didn't know your name because your name said Dr. Ihsan. So
I am Dr. إحسان حسن الدباغ, كلية الطب, جامعة الموصل.
Welcome. Thank you.
Thank you.
Dr. Ammar? Okay. Dr. Mariam.
Sorry?
Okay, Dr.
Yes?
Ammar. Okay, Dr. Ammar. Okay, go
Good
ahead.
evening. Assalamu alaikum. Good evening, everyone. Thank you for this lecture and this about the information about COVID-19. Sorry, I want to ask about which kind of protein which kind of sequence of amino acid can be damaged from COVID-19. And thank you for this information.
Thank you very much for your question. So in terms of the amino acids that are effective, from my brief research, the only ones I am familiar with is the amino acids contained within the viral RNA. I don't know off the top of my head which amino acids they are, but it's essentially the DNA or the viral RNA that's contained within the SARS coronavirus, which is then entering the nucleus within the human cell and then interrupting the DNA process there. So I'm not too sure off the top of my head in terms of the specific amino acids, but what I would say is that it's the amino acids involved in DNA replication. So that's kind of the only thing that I can really touch on with that. I would have to do a bit more research to specifically know about the DNA, the amino acid sequence that is interrupted. But yes, as far as I'm aware, it is just the ones that's involved in the DNA sequence.
Okay, thank you. So Dr. Mariam, another question from Dr. Mariam.
Okay. Good evening, everyone. Thank you very much for this useful lecture. Please, I just want to ask you, as you say, the viral is just contact to ACE2 receptor. And we have in medicine ACE blocker used to treat the patient with elevated blood pressure. It is an antihypertensive drug. Does there any trial or uses of these drugs or medication to reduce the entry of this virus to the cell to decrease its replication within the cell? There's any trial of this medication to be used in purpose, for example?
So there has been a lot of research in terms of the use of ACE inhibitors and also angiotensin receptor blockers. So this is stuff like ramipril, and commonly ramipril, but we also use lisinopril as well. So these medications, like you said, they are treating hypertension in a lot of patients, so high blood pressure. Now, what we're kind of telling our patients is that those patients that already have high blood pressure and that they don't have symptoms, we're not advising them to stop the ACE inhibitor, purely because it is treating another condition of theirs. They have hypertension, so we don't want them to then develop very high blood pressure that is uncontrolled. However, in those patients that are coming into hospitals, we are stopping the ramipril, we're just holding it, or we're stopping the angiotensin receptor blocker, purely because it's kind of counterintuitive. So an ACE inhibitor will block the ACE receptors. However, as a result of that, we see an upregulation of ACE receptors. So it's helpful in a sense that it's blocking the ACE receptors and it's reducing the hypertension. But the side effect of that is that we generally see more ACE receptors being produced because they are being blocked. So in those patients with hypertension, or those patients that have diabetes, or those patients that are on ramipril or on lisinopril, those patients tend to have a higher number of ACE receptors anyway, which is why these patients are at a higher risk of developing more serious disease from coronavirus. So there is not that much information out there to say whether or not we should be stopping these medications in patients. But when patients are coming in, I'm basically taking them off the ramipril or the lisinopril and just holding it until we know for sure whether or not the ACE inhibitor is affecting that patient negatively. And we tend to just manage the blood pressure with other measures. So that could just be putting them on a calcium channel blocker in the meantime. So something like amlodipine, or just managing it using fluids as well. That tends to be more of a approach there. But I understand your concern, because the ACE inhibitors and the angiotensin receptor blockers have been a talking point for a lot of clinicians and also a lot of researchers. But generally, we've been advised to not tell patients to stop them until they're critically unwell and they come into hospital. But we ideally, if a patient doesn't need it, we're saying that we should stop it, because we're seeing that they have an increased number of ACE receptors, which just means that the virus has more places to bind to and will enter more cells in that sense.
Okay.
Thank you very much, Dr. Ayat. We're going to stop here. So, شكرا الجزيل لكم.
Thank you very much.
Thank you very much. الحقيقة كانت محاضرة جدا رائعة، وأعتقد يعني
تسلم، شكرا. Thank you for having me.
حسب المعلومات القيمة اللي قدمتيها. نتمنى أن نلتقي معاكم في محافل علمية أخرى ويكون يزداد التعاون ما بين كجامعة القادسية وما بين سواء كان نوتنغهام يونيفرسيتي هوسبيتال أو أي مؤسسة علمية في المملكة المتحدة. الشكر
إن شاء الله. إن شاء
الله. الشكر الجزيل للجميع الاستماع، وكذلك الشكر الوافر لفريق الدعم التقني أكثر من رائع اللي هم حقيقة جاي يبذلون جهد كلش كبير، واللي هو برئاسة السيد المعاون الإداري الدكتور حميد الجبور وكذلك السيد وسام العيساوي. أكرر شكري وتقديري للدكتور اياد غفوري، وإن شاء الله نلتقيكم في محافل علمية أخرى. شكرا جزيلا.